All right. Well.
All right. Sorry about that, guys. We have a very intimate group here today. So hopefully that will stimulate some great discussion. So just understand how we structured this session, and Rebecca kind of gave it a really nice introduction. One of the areas of, I don't want to say controversy, but really it's kind of emerging and becoming more relevant to this field now is the utilization of ovarian tissue that has previously been frozen. And one of the kind of areas that we've identified as a potential gap in really kind of pulling together the literature that is out there with respect to transplantation techniques. And then to kind of scale back on that, we thought that now might be the right time, kind of 20 years out from the initial live birth from OTC, to really think about what are the best practices involved in this process. So over the course of the next hour, we are going to kind of speak through some of the elements that we think should go into a guideline or white paper on this topic. And then really we want to utilize this time to have an interactive discussion and have a work product at the end of our meeting. So a little bit different from some of the other committee sessions from this morning. So to start off with, I'm going to speak a little bit about preoperative considerations, and then Rebecca will speak about different operative approaches to the initial ovarian tissue harvesting, and then Mindy will speak about post-harvest utilization. And then we'll move into breakout groups, and because of the intimate nature of our meeting, we will probably, instead of breaking out into separate groups for each of these three components, begin discussions, actually probably working backwards through what do we think is most relevant to include with each of these, and then kind of come together to, again, at the end, talk a little bit about proposed guidelines. So I'm going to start off with preoperative considerations, and really just this is speaking to the idea that there are a lot of different, groups that may now be considering ovarian tissue cryopreservation. And while, yes, this is the Oncofertility Consortium, and we want to make sure that we are appropriately kind of guiding any work product in the direction of patients that have a history of cancer. We also need to have a better understanding also, though, of who all is being referred for ovarian tissue cryopreservation. I'm going to speak through a little bit of what we believe are some of the advantages and limitations of ovarian tissue cryopreservation, and some of the areas of controversy that would be important to address, including optimal age range to offer this treatment strategy, the role of different elements of preoperative testing going into tissue cryopreservation, and then certainly the other factors that need to be considered in preoperative planning. So to start off with, cryopreservation indications. Classically, we think about kinetotoxic medical therapy as one of the primary reasons why we might be seeing these patients. And this may be patients with malignancies, but as we all know, there are also other non-malignant conditions that may be appropriate for this, including rheumatologic diseases that for which patients might be receiving chemotherapeutic agents, as well as some hematologic diseases. Certainly, there are patients that might be getting directed radiation therapy to the pelvis that might be impacted, and this may be there may be a role for OTC in those patients. Also, there is a body of literature regarding genetic and autoimmune conditions associated with premature ovarian insufficiency. For example, patients with Turner syndrome, patients with galactosemia. So there certainly could be a role for these patients as well. And then additionally, we have a large group of patients that are coming for fertility preservation prior to gender-affirming hormonal or surgical therapies. And while, I think we classically think about mature oocyte cryopreservation as an option for those who are born female assigned at birth, depending upon the timing, ovarian tissue cryopreservation may be an option for these patients. I think some of the other areas for kind of emerging discussions also are, is there a role for ovarian tissue cryopreservation amongst patients that are undergoing different gene therapy treatments, as well as at Escher a few years ago, there's a talk about those who are using ovarian tissue cryopreservation, or could we be using it for those who want to delay the symptoms of menopause? Now, when we think about OTC in general, think preoperative considerations, we also need to think about how we're counseling patients about the advantages and potential limitations. So we know that some of the advantages can include that you can cryopreserve thousands of eggs at one time. It's a relatively simple procedure, usually done as an outpatient, and there's very little delay in starting therapy if gonatotoxic treatment is impending. In theory, it can also be performed after exposure to some chemotherapy, and we now have literature and case series that have reported on success in these scenarios. And most importantly, this really is the only option for prepubertal females at this time. Some of the disadvantages, so it does require surgery to remove and replace the tissue at a later time. And there are still ongoing discussions about the risk of transplanting tumor cells, whether or not this is a concern. One of the other important considerations is depending upon the age of the patient, techniques like pre-implantation genetic testing may be limited when it comes to ovarian tissue cryopreservation, and then those who need to use a gestational carrier, this might be a more challenging route, just given what we have seen in terms of IVF after transplant. Also, in vitro maturation techniques are currently not part of clinical standard of care. This may be something that evolves with time and as we learn more, but this is one of the considerations along the way. Another, I think, point of discussion and something that is would be very important to include in any guideline is discussions around the optimal age for doing this. So I think we can all agree that this is ideal for prepubertal patients, depending upon what their impending risk might be. There is certainly a role for utilization in post-pubertal patients as well. And the question here is, to what degree does the indication for why they are pursuing ovarian tissue cryopreservation play into this optimal age? And this is particularly important in those patients who might be presenting for with gonatogenesis, like Turner syndrome, for example, where we don't know exactly when, that they may tip from, kind of some degree of ovarian function into premature ovarian insufficiency. And, finding that optimal window can be challenging. Certainly, thinking about gonatotoxic exposure, so, not just kind of the initial insult, but also potential for needing additional treatments throughout their treatment course. And is there a maximum age at which we should be offering this? And I think that's an area of some degree of debate in terms of thinking about how this tissue might be utilized in the future. Now, in terms of the role of preoperative testing, so I think many have discussed that having some degree of a metric of AMH, anti-Mullerian hormone or antral follicle count, may be helpful in establishing a baseline ovarian reserve. And there have been some studies in adults that AMH may predict ovarian recovery after gonatotoxic treatment when taken into consideration with the proposed treatment, as well as what their baseline ovarian reserve may be. What we do also know, though, is when it comes to ovarian tissue cryopreservation, biomarkers of ovarian reserve do not predict follicular density in patients prior to gonatotoxic therapy, and that serum AMH levels and follicular density have been shown to be moderately correlated in some, but not to the degree that it can provide a reliable estimate of kind of either follicular density or utilization in the future. We also know that in those patients that may not be kind of going through gonatotoxic therapies, that biomarkers of ovarian reserve do not predict follicular density in these patients well at all. And there are other considerations around, the role of karyotype and other clinical factors in these patients. But I think the consensus at this point is that there is not a great biomarker that can really tell us how this tissue may be utilized in the future, but there may be a role still for doing this testing, just to be able to counsel patients about, this is where we are starting from. Now, I know that this is not news to this audience, but I think any sort of counseling about preoperative consideration should also include what are the data that we have regarding OTC success. And so this slide comes from a study that was published in 2021 in Fertility and Sterility that was a case series of 285 women and included 351 transplants. And they published, the age at cryopreservation, the age at transplant, and really showed very promising endocrine function rates of return, as well as, very, very promising pregnancy rates and live birth rates overall. Importantly, we're now at this stage where there have been, hundreds of live births from autologous transplantation. And so, providing ongoing data about what these success parameters look like is going to be important. Also, part of that discussion needs to be a discussion of the risk. So while we think about OTC as a relatively minor procedure, all surgeries come with risks, so that does need to be part of the conversation: bleeding, infection, damage to surrounding structures. But also there does need to be some discussion about future utilization and recognizing that anytime you intervene, patients should be counseled about what's the likelihood that I'm going to use this tissue in the future and what is known about that utilization. So that also then plays into discussions around the cost effectiveness of this treatment. Another concern that has been raised is this concept of reintroducing malignancy. And in particular, there have been several reviews that have looked at different cancer types, different treatment types, and where are the areas potentially of greatest concern. Historically, leukemia has been a concern, as well as certainly ovarian malignancies, and those that may not have active malignancy, but may be at high risk, like those with BRCA mutations. Now, interestingly, since this data, there have also been case series reported of patients who had a history of leukemia that underwent OTC and once in remission, prior to their transplantation, and discuss this role of actually screening the cortical strips for leukemic infiltration by different histologic, immunologic, and molecular markers. And the great news with this case series is that in this follow-up period of 51 months, all of them were disease-free. They did mention that one had the graft removed during C-section, and that actual graft was also tested and noted to not have evidence of disease. So this is very promising, and some of the original concerns that we had there may be strategies to circumvent them. So, at the end of the day, we always need to kind of balance risk benefit. And anytime we have these conversations and discuss what's our rationale for treatment, what role do age and pubertal status have, ovarian reserve at baseline, kind of prior to tissue cryopreservation, either in the form of biomarkers or kind of the discussions around pubertal status and ovarian function. As always, patient's health status is an important part of this discussion in terms of ability to tolerate this procedure, as well as kind of discussions about future utilization themselves versus the role of scenarios like using a gestational carrier. Prior exposure to gonadotoxic therapy. Again, this is, one of the areas where we do have data now regarding success after gonadotoxic therapy. And certainly for these patients, the availability of fertility preservation services. And certainly with this week, there's been discussions about how that might evolve. So not just thinking about the time at which it's cryopreserved, but also the time at which it's utilized. And so thinking about kind of the cost of treatment, storage, future transplantation, and then the social and ethical considerations around that. Of course, I think probably one of the most important things that we can all agree is the importance of individualizing counseling for these patients. So this is where, our goal to develop guidelines or kind of best practices is very important, because we want to be able to consolidate the evidence, but also reiterate the importance of personalizing care. So with that, I'm going to turn it over to Rebecca to talk about operative considerations.
All right, great. Thank you. I think we have the introduction and the first section pretty well sketched out as a result of that, but I'm very interested with our brainstorming session to see what we can add to that. And so that'll be part of that next exercise. I'm Rebecca Flyckt. I think I know most of you. I'm from Cleveland, and I will be talking about the operative considerations. So I think this can kind of be broken down into several categories. how are we going to approach these procedures? How do we optimally work with other service lines to deliver smooth care for the patient? When we actually get to the ovary, there's been, a huge change in how we handle things. But I think that change has occurred in a relative absence of really strong data. And so I think that's another thing we have to be thoughtful about. Specific surgical techniques and what kind of energy, or do we use energy in our handling of the ovary? And then lastly, how do we get the specimen out of the abdomen, and how do we prepare it for transport? So I think that as a general theme, we have largely moved as a field towards a minimally invasive approach. And that's consistent with lots of areas of gynecology. There's this evolution from big open surgeries, and then you do some laparoscopy, and then maybe you do some robotics. And I think that we're starting to see that with ovarian tissue procurement. All of the benefits of minimally invasive surgery apply when you get to removing an ovary for ovarian tissue freezing. The reduced recovery time, less of a chance of adhesion formation. And for those that are very much thinking about future fertility, remember egg pickup happens in that posterior cul-de-sac. So any surgery that happens there that causes adhesions can interfere with future egg pickup. The other benefits of minimally invasive surgery are that there's very few risks. Of course, everyone fills out a consent form, but these are pretty minimal procedures. And then the post-operative risks are also minimized. So although I know that there are some that continue to perform laparotomy, I think most of us at this point favor a minimally invasive approach. As far as the surgical coordination, and this is where kind of the practical element comes in, I think most of us that run these kinds of procedures at large hospitals are very familiar with trying to coordinate with ped surgery for putting in a line, or trying to coordinate your procurement of the ovary with a concomitant transposition. Some of these patients actually do have abdominopelvic tumors and are getting other kinds of surgery. Can you go in and grab an ovary at the same time? So I think learning what works in your local ecosystem is so important in making a program like this successful. And I think if we don't call that out, we're kind of missing a major part of how to make these procedures smooth and effective. Kind of along the same line, having built an ovarian tissue program at a couple different institutions now, I think one of the key lessons that I learned, and now as we're rolling out a new clinical trial, I'm learning again, is that you can never think enough about how many stakeholders you have to engage at the outset. There's always someone that you forget. And then when you go to do your first procedure, that's going to be the person that's pissed off. So thinking about that in advance and making sure you get in front of them, painting the picture of the need and how you're going to make this easy for them is a big part in building a surgical OTC program. And then lastly, you have to kind of know your local institutional policies and procedures. So at one of the places where I am, you have to do the surgery with a pediatric surgeon, even if you're credentialed to do pediatric surgeries. So I think that's a big difference for me from where I came from. And there's lots of other things that are institution specific. I gave a talk about this here a few years ago, thinking about what's better, decortication versus oophorectomy. And at the time, the room was pretty well split between who was doing what. At this point, and I'd love to see a show of hands, how many of you are taking out the whole ovary? Yeah, it's almost everybody at this point. I don't know that we actually have the data to support one versus the other. And I think as you think about it, there's really benefits on both sides. I will say my personal surgical practice has moved more towards whole ovary procurement. But I started even doing these circular biopsies, which were initially reported by Georges Miro. In 2014. And you do get a reasonable follicle density from that, especially if it's a pediatric patient. But then more and more, we kind of did the partial cortex removal, and now I do the oophorectomy. But I'm not saying that any one of these is better. And if you really consider this thoughtfully, and these are pictures from how I used to do it, monopolar hook, monopolar energy, you have to really surgically know how to find that cleavage plane between the cortex and the medulla. There are some benefits to the decortication, which is now that we're getting to the point of reimplanting tissue, and again, there's just not really as much data as we would like. Is it helpful to have that medullary stump and the vascular supply that comes through that pedicle in place? I will be perfectly honest, I've never done a tissue reimplantation in a human, but I've done it in lots of animal models. And when I do it in an animal model and you have these tiny pieces of tissue and you're trying to drop it into a peritoneal pocket or sew it, it's actually extremely difficult. And the pieces get lost or they migrate. You got a little ovary over here, a little bit over there. So I think it's very important to be thoughtful about how we're getting these ovaries, because there is a point where we're going to be putting them back. And I just don't think that we know enough about that. And then there's always the thought that if you do a partial cortexomy or whatever we're going to call it, that you would still have some residual function in the ovary. Like lots of these are young patients, and I'm constantly humbled by how resilient the ovary can be. I think as far as benefits to oophorectomy, we've all got those sick patients that just can't go through a difficult surgery with a risk of bleeding. It's like, an attack. You're going in, you're getting the ovary, and you're getting back out. And so the quickness of that surgery is one of its benefits, as well as the potential for less thermal damage to the ovarian tissue, which is so precious. In doing these on pediatric patients down to, I think 2 was the youngest. I mean, the scariest thing as a gynecologic surgeon is the fact that the ureter in a pediatric patient is really close, even closer than in some of the, other surgeries that we do. And, I think it's well acknowledged that the natural predator of the ureter is the well-meaning gynecologist. So I think that we have to be really thoughtful in our pediatric patients about, like where we're taking that pedicle. And then lastly, sometimes in a pediatric patient, it's hard to even find the ovary, and it's very, very tiny. So you can't do like a decortication on an ovary that's less than a centimeter. And then the final benefit of oophorectomy, I think, is something that will continue to emerge, which is it gives us the opportunity to do IVM from the ovarian tissue in vitro. So I think that that's going to be important vote in favor of taking out the ovary. As far as selection of the ovary, most of us take out the right one. It's easier. There's no rectosigmoid there that you're going to potentially cause damage to. But if there's pathology or if you're going to do a transposition, most of us like to transpose the right ovary and remove the left ovary because that transposition is going to be less morbid on the right side. So there's particular situations that might cause you to pick one versus the other. I think we have yet to determine what is the optimal pedicle length on the IP and on the ovarian ligament. I think most of us, usually it's going to be half a centimeter or a centimeter, but the farther back you go, the less thermal spread, but also the more potential for injuring something like a ureter. I think there's an ongoing debate about thermal spread and pressure to the ovary. And so this was a really, I think, important picture that was in this article from 2024. Aaron Rowell was the author on this, but basically showing the ovary on the left with thermal damage, and they had to sacrifice that whole portion of the ovary that you see below the line, and then, above the line. And then there's also kind of a pressure or a crush element in the second one, and then it's both in the third one. And you can just see how unhealthy that ovary looks. And so again, how we set things up in advance is critically important to what we're going to be able to use in the future. And I think we're just starting to have some of these like surgical type discussions, which are going to be so important. I thought this was another great publication in, this is a different one from 2024. Actually, this is the same one with Aaron. But in any case, they surveyed 18 centers in England and Wales, and they had a 100% response rate. I don't think I've ever done a study with a 100% response rate, so good on them. But it was a survey in the UK, and basically it showed, the widespread acceptance of laparoscopy. 82% were doing that. 7% were doing it with a single port. That's another thing I think we have to call out, which is like single port is fine. I do it in some adults, but like try doing a single port in a 2-year-old. Like it's just not going to happen. And so some people are using single port and some people are still doing open surgeries. Almost all of them, and this reflects, I think, sort of the gestalt right now, are performing oophorectomy. And I thought it was interesting that a lot of them are using a ligature. We've started to sometimes use an endo loop to avoid thermal injury. But I think ligature is still far and away the most common if you look at all of the different sources of energy that are available. And then going back to any kind of tissue procurement and freezing, the concept of warm ischemia time is something that we really need to start thinking about more. It definitely should be minimized. And actually, Falcone and others published, this was back in 2001, that if you look at sow ovaries, the ischemic time, as long as you kept it less than 30 minutes, really didn't significantly decrease the primordial follicles. And so I think we have some wiggle room, but probably not as much as for some of us it takes to get it handled and processed. As far as the UK survey, about half are putting it in a bag. I thought that was really interesting. And they basically made the decision by whether they could wiggle it out of the umbilical laparoscopic camera port, which is mostly what I do. I'll put it in a bag sometimes, but I think if it fits out easily from the incision that you've made, it's not like endometriosis where you're worried about contamination. And then I think the key thing from a surgical standpoint is sometimes I see people just like grab the ovary and it like makes you wince. Like you really should be grabbing at that lateral pedicle. So that's about all I've got on the surgery side. And I just want to welcome Mindy Christianson.
Great. Thank you so much. I'm going to kind of finish up our summary of some of the data and information we have regarding ovarian tissue cryopreservation before we have our group meeting and kind of start discussing some of the guidelines we want to focus on. So my topic is on post-harvest considerations. So we have this ovarian tissue that's frozen. And if you're like me, you may be having patients coming back wanting to use the tissue. So the question is, what are the best practices at this point? So there's a lot of post-harvest considerations, and the scope of this, that we could have an entire meeting, just like talking about all of these different considerations. So after you harvest the tissue, what is the best way to transport it? How should it be transported? How long can you hold it before you actually freeze the tissue? Once the tissue is cryopreserved and you want to use it in the future, how should it be tested? And should it be tested before or after freezing or both? And then using it in the future. Obviously, there's the clinical use and then research use. And so there needs to be guidelines regarding research for sure, because of the ethical issues involved, but then clinically, and this is kind of where a lot of people are having questions, is we have these patients coming back right now. All of the live births to date have been from transplanted ovarian tissue. What are the best practices for transplanting this tissue? Where should it be transplanted? So those are all really good questions. And then finally, disposition, there's legal and ethical issues. And so there really needs to be guidelines and agreement as a specialty and how to manage that. So as far as, so my slide's in the wrong order. Here we go. So as far as transport, so there was actually a really nice systematic review that was done looking at ovarian tissue transport. There was 46 studies to date. I did not realize there were this many studies looking at the transport of ovarian tissue. 6 studies were done looking specifically at humans, and kind of based on the data we have, and there's been studies looking at the best transport and time to cryopreservation. It appears that up to 24 hours is likely acceptable. So that's nice, but there are guidelines for future studies, things we don't know, like understanding ovarian tissue metabolism and being able to kind of look at other organ studies and what data we have and the cryopreservation technique. And then, so there are some obviously guidelines for future studies that we would put in a paper. And then assessing the ovarian tissue. How should we assess it? Should we do a biopsy of the tissue before it's frozen to look at the follicular density? There's been a lot of research looking at xenotransplantation. Is that how we should be testing the ovarian tissue, and then tissue analysis? So there are many different methods that have been described for testing harvested ovarian tissue. And this is going to come up before you transplant the tissue, if that's what you're going to do, like what testing should we have done? I know at least 2 patients that have presented at the Cleveland Clinic that wanted to have tissue transplanted, and both of them, these 2 particular patients, there were actually cancer cells that were detected on the ovarian tissue. So that was not an option for them. And so when should that testing be done? But then histologic investigations, looking at follicular density, tests to look at the viability of the ovarian tissue, and then exclusion of malignant cells. And then functional investigation to confirm endocrine or reproductive functions that would take place after the transplantation. And there's been described different techniques and times to do that. So there's really a lot of tests available for harvesting ovarian tissue. And if you talk to people who've transplanted the tissue, some are doing testing, some are not, but having some standard guidelines. And I think that, particularly hematologic malignancy, you would definitely want to test the tissue. And so this is just kind of a summary of what to date many places are doing. They're harvesting the whole ovary, like Dr. Flyckt described, preparing it in the lab, dissecting the ovarian cortex, and then dividing it into strips. And then there's also a lot of question about like what size the strip should be, how many millimeters thick they should be, that people ask a lot of questions about. At least I know people reach out to me and ask questions like that. So I'm sure that it's nation and worldwide. And then freezing the tissue. And then, like I said, to date, the live births have been from transplanting the tissue. And so there are a lot of different reported methods of transplanting ovarian tissue. Some of them have been described by Dr. Octay, Dr. Denay, Dr. Myro. So lots of different ways of doing it. And I have some quick slides at the end of this presentation that kind of go over all of the different techniques. But what we do know is that after we transplant the tissue, there is a loss of ovarian reserve. And most of it, like we're losing ovarian reserve just with, the graft preparation, the freezing, but it's really after you transplant that tissue and as it starts to kind of develop a blood supply, you have this post-graft ischemia that results in follicle loss. And so that's where we're losing most of the follicles. And so people have reported various techniques for how to optimize that. And so because of this, there are a lot of different questions about the best practices for transplanting ovarian tissue, how we can avoid the ischemia, the best operative technique for transplanting, the best site. But what we do know is that the vast majority of cases where we transplant ovarian tissue, hormone production is restored in over 95% of cases, which is amazing. Ovarian function resumes anywhere from 60 days to 240 days, but on average, it's usually around 3 months. And then how long the graft lasts is going to depend on the size of the graft, the number of strips you may transplant, as well as the follicular density of the graft that you transplant. But just kind of to go over the different surgical techniques. And so this is one that Dr. Octay, he does quite a bit of transplantation. He likes to use alloderm as a scaffold and suture the small pieces of ovarian tissue ahead of time on the alloderm. And then he's done it robotically as well as laparoscopically, where they've just put it on the other ovary. And so if you have a patient where you remove one ovary and leave the other, transplanting the tissue on the other ovary has the advantage of it's anatomically in the right position to aid in unassisted pregnancies. So that's one advantage. This is one technique that has been described. And then another technique also described by Dr. Octay is this is actually a heterotopic graft, so in the anterior abdominal wall, so not actually in the pelvis. I think this was a patient that had pelvic radiation, so it wasn't a good environment to put it in the pelvis. And this actually did result in a live birth. There's also a tunneling technique, which has been described where the strips of ovarian cortex are actually transplanted into a tunnel of the existing ovary. And then finally, Dr. Denay actually has reported transplanting into a peritoneal pocket. So as you can see, there are many different techniques reported, and we really don't have an established best practice. And then I'm going to go over this fairly quickly since since this has already been reviewed where we've looked at pregnancy rates after transplantation. So I'll kind of skip over this. And so next, what we're going to do is have a discussion. We're going to have breakout sessions to talk about these 3 areas, but I think we have a small enough group that we can all as a group discuss kind of practice guidelines. And so we have about 15 minutes left for this session. So I think what we could do is just people, if anyone here would like to kind of share what their thoughts are, and then we'll take notes as well. What our goal is, and I know Dr. Flyckt mentioned this at the beginning, is we'd like to actually develop a practice committee guideline. These would be practice committee, surgical committee guidelines for best practices for ovarian tissue cryopreservation use. I know we covered a lot, but does anyone have any experiences or questions that they would want to make sure we addressed in such a manuscript?
Manuscript is a good idea. Is there enough there that you can put something together that would make a meaningful contribution? I just sent to email outline of what we talked about today, and then we can start filling it in. But do people think that this is a good idea? Okay.
Great.
Great. So let's start working on it. And I think that this can be very small because we are very small but mighty today. And if you can access your email, it should be.
Okay,
I
perfect.
tried to take the PowerPoints and put them in a Word document just to kind of sketch it out. I wanted to engage our folks online. Any thoughts? It looks like there's something in the chat. Are you able to? Oh. What's that? Oh, sure.
Oh, Leslie's got the mic. Okay.
Okay, so before we dive into the outline, anybody who has anything they'd like to contribute, or anybody out there in the virtual audience who has thoughts on this? Yeah. How organized.
Wow.
Anything last year is if we should be doing different social activities based on age and people status. Because I think the end loop is a great idea for some of the younger kids, but I worry about disclosure on our teenagers and not using it something that's advice. And I haven't seen that in the first one of the selling number time conversations and a lot of those kids and that's
Okay, so I'm going to put this in this section here, thermal spread and pressure. And I'm just going to say, could we triage based on
Yeah, I think that's an excellent point because it's a fine balance between you want to do this quick, safe. And safety is the most important because this is an elective procedure. So when I first started doing this, my main priority is I want no complications at all. I want this as safe as fast as possible. So anything to avoid bleeding, obviously we want to do, and while protecting the integrity of the tissue. So I think that's an excellent point.
Absolutely. Excellent. Any other off the cuff kind of reactions or thoughts?
Get a cocoa. Give a cocoa moco.
When you say the middle group, do you mean the genetic autoimmune? Yeah. That's a great point.
And I think also the point about hematologic malignancies and, we often would not be able to transplant that tissue in the future. But hopefully in the future for especially pediatric patient, we'll be able to do in vitro maturation in the future. So that's what we're promising people or what we're looking at, but we don't know for sure that's going to happen.
How much we struggle to type. Okay. Anything else for this first part of like who's being referred for ovarian tissue cryopreservation? Anything else to add to make this a richer discussion?
I think also this came up for me recently, but pre-harvest recommendations, are we always doing an ultrasound to confirm there's ovaries before we do a laparoscopy on someone to, I think we stopped doing that, but one of my patient's fathers just asked me last week, are you going to do an ultrasound to make sure she has ovaries? I mean, so that's like, do we do that or not? I mean, so that's like something else that we should like recommend or not recommend. Right, and there should be a whole section on Turner syndrome mosaic patients because like some of them have ovaries, some of them do not. And just like a whole, I didn't think a section on that. There's been enough published.
Part of the question that we're going prior to practice.
There's a better way I can put that. Let me know.
Oh, there's a question in the chat. We can't see the chat.
See it.
Can you hear me? No, I don't think so.
The last part require what? Minimal residual disease negative. Interesting. At the time. Oh, that's it. Okay. I don't know if everybody heard that, but sort of thoughts about whether institutions should require prior to retransplantation that someone has no residual disease or minimal residual disease. I think that's a really interesting ethical question. And it makes me wonder if what's missing from our outline is just overall bioethical considerations. I think that could probably be a standalone for all of these kind of complex situations that we're mentioning.
Right, but I think that we would not do a transplantation without having oncology support. So it would be a collaborative decision with oncology. And so if oncology felt that the risk of recurrence was low and advocated to transplant the tissue, then I think that, but I think we should have mentioned something in the manuscript about oncology support, shared decision-making with oncology.
That I think we spoke about that here. That we have parents, patients with MRD positive, and still want to go forward with the disease. That's not study.
Oh, freezing tissue when there's disease, or
like the ovaries diseased? In the hope that, I guess we're saying like in the hope that we can do IVM. And then
I've seen that with G1 oncology cases where like one ovary is already removed, there's a recurrence on the other ovary. If there's any normal tissue, will you just freeze it? I've run into that case before, and we decided with oncology if there's something normal occurring, we would freeze it. But the transplantation would involve, like, most likely we wouldn't transplant in the future. But so I think we could mention something about those difficult situations and.
My TV.
That's actually a very good idea. Now, I'm actually thinking we might have enough material just to do one manuscript on like selection, patient selection. Preoperative, because there's a lot.
I'm putting Leslie in charge of that.
A series.
All right, we probably are not going to get to all of our subheadings. I think there's probably more advantages and disadvantages that we can kind of flesh out. I think we talked a bit about this age range. Are we missing anything else from preoperative counseling and assessment?
And then infectious disease, testing for freezing. I know like in the United States, there's like regulations, but like kind of worldwide best practices for infectious disease testing.
And I think the practical element is that I think a lot of us are sending the tissue to long-term storage. And so, like they won't accept it or accept it at the same rate if we don't have the infectious disease testing updated. I'm just going to scroll through to see if anyone has other food for thought here. Do we think that we have most of the risks outlined here? I think so.
I think so.
All right, in the operative section, any feedback about like our specific surgical techniques for gaining access to the abdomen, for removing the ovary, for whether to do decortication versus oophorectomy? I just think there's going to be so much interest now, and you can see like the number of publications in 2023, 2024 are escalating. Like everybody that's putting tissue back is now realizing that like how we set it up may not have been ideal. So I think this is a very important section. There's some data, there's not a ton of data.
Right. Then also like a lot of times it's piggybacked with like placing a port and, then who's doing, so a lot of times it might be pediatric surgery doing it because they're there and
yeah,
just kind of mentioning that a little bit.
I think we could probably make some recommendations about optimal collaboration.
Need for collaboration.
Yeah. And I think at some places it's mostly PAGs that's doing it. At some places it's pediatric surgery. At some places it's REI. So like, how do we coordinate for standardization of care across all these disciplines?
Time. So I think we're at our time limit. I think we accomplished a lot. Moving forward, what do people think about reviewing this to continue both with the surgical committee, and then the practice committee? We'll have more people as well.
Yeah, I think what we had in mind is that this can easily go into a Google Doc. We can continue to flesh out the outline. We can have a Zoom and, get additional feedback. And then I think we can divide and conquer, and each person or who wants to be involved can write up a specific section. And then kind of like we do at the practice committee, we can start to ask people to put comments in the margins, and then we can meet again to incorporate the comments. So I think that this is something that we could turn around in the next 3 to 6 months. Sure.
Well, it might be more than
Aim for
one.
the
It
stars.
might be more than one. We should at least get like.
All right. Thank you for your engagement. I'm really excited about this. I know Mindy is too.
excited. And Suneeta, we're all excited.
Yes.
Yes, thank you.